My name is Dr. Richard Hilsden, and you're watching Knife Skills. Today, I wanted to talk about tests and test accuracy. I was on Twitter a few weeks ago, and one of the criticisms about the whole COVID-19 response was this idea that the tests we're using are not very accurate. And that led to a bit of a back and forth on Twitter where I realized that most people don't actually understand what is useful and what we mean when we talk about accuracy in testing. So I wanted to spend a few minutes and talk to you a little bit about some tests that are being developed, as well as how doctors and health providers look at a test to evaluate its accuracy. So some terms right up front. So the first term that is useful to mention is sensitivity and specificity. So sensitivity is this concept that if someone has the disease, the test will be positive. It's sensitive. It picks up the positive tests. What that actually means from a provider's point of view is that a highly sensitive test will rule out a disease if it's negative. And that's an important concept. The next idea that's related to sensitivity is specificity. And again, the thought works like this. The specificity of a test helps to rule a disease in. So if someone has a positive test, then it's unlikely that it's positive for another reason. They have that disease. So since specificity helps you rule in the illness. So I'm going to turn to the computer here and show a Wikipedia graph that will help you here. So this is a complicated diagram from the Wikipedia article. There's a lot of extra things here. So what I'm going to do is I'm going to show you the simpler version here. And we'll zoom in a little bit. I've just made it a little bit simpler. All right. So here we have the set conditions. So we have the groups of patients who have the condition and groups of patients who don't have the condition. That's condition negative and condition positive here, okay? Then we have the results essentially of the test here. So if the test is positive and the condition is positive, we call that a true positive. If the test is negative and the condition is negative, we call that a true negative. And so as we were saying with sensitivity, a sensitivity here is going to be the true positives over all of the conditions that are positive, okay? And then what that tells us essentially is that, again, ironically, if that test is negative, it'll have a low false negative rate because the false negative number will, if that increases, your true positive number decreases, so your sensitivity decreases. Same thing here with the specificity. It's the true negative over all the negative tests. Again, we want to know if we can rely on the positive test. So a highly sensitive test is going to have a small number for false positives, and so therefore that's going to increase our sensitivity by having a low false positive rate. Now, I brought this graph up because that's the test characteristic, but we also want to know how things perform on an individual basis. And that's actually a slightly different calculation. That's called positive and negative predictive value. And you'll notice there's a slight difference here in how these are calculated. So again, we have the true negative conditions here for the negative predictive value over all the times that the test is performed negative. Okay, and that's different. And the reason why these are relevant is that the prevalence of the disease in the population will have an impact on the positive and negative predictive values. So a test that performs in a population with very few conditions, very few of that illness is present, and that test is negative, that will increase its negative predictive value. Same thing. If you're in a population that has a high prevalence, there's a lot of that condition in the population, then that will increase your positive predictive value without having any impact on the test characteristics itself. So when we talk about positive predictive value, it's a combination of the test characteristic and the characteristics of the population. Whereas the sensitivity and the specificity of tests don't change depending on the population. So let's move forward a little bit to the receiver operating curve. Now this is actually how we in real time determine optimal test. So just to get you a sense here of how this curve works, we have the sensitivity on the left side and the specificity on the bottom here. So on the x-axis and the y-axis. A test that falls along this dotted line is a random guess. It's not a useful test. It doesn't help you at all. Tests that essentially fill the entire upper left side, the area under the left side, they would be 100% specific and 100% sensitive, would have a dot here at that 1. Now notice that the x-axis is 1 minus specificity, so it's an inversion of the specificity here. So high, the more specific the test, the more the graph will be to the left. Okay, if we didn't invert it, then a perfect test would fall along the random guess line, and we don't want that. So this graph here, also from Wikipedia, helps us a little bit understand this. So here we have true positives, true negatives, and this is the position along the receiver operating curve that our test characteristic is on. So we can oftentimes with tests choose a threshold. So if we were to move this bar to the right, okay, we would actually be decreasing our false positive rate because it would come down this true negative line, but it would be increasing our false negative rate. We have more negative tests that weren't actually negative. If we move the test to the left, again, our true positive rate will increase, but we'll sacrifice that on the true negatives. We'll actually have more false positives than we should, because these negative patients are going to be captured by that. So finally, what's an ideal receiver operating curve? Well, the receiver operating curve that actually is more up in the left upper quadrant is the ideal receiver operating curve. There's more area under the curve that has the best compromise between sensitivity and specificity. So finally, I wanted to show you an interesting article that came up across with regard to COVID-19 and antibody testing. So when we take patients who've been proven positive, and we're in this case comparing the gold standard, which is the real-time polymerized chain reaction, that is the test, the nasal swab, nasopharyngeal swab that people are using, plus symptoms, because we want to make sure that this patient truly has the disease. Then they're doing antibody studies to see which antibodies are going to be accurate. And here on our screen, we can actually see a bunch of receiver operating curves showing the various antibodies that are being tested. So, for example, if we take a look at the IgG antibody, a particular type of antibody, the receiver operating characters are very strong. You see it's almost a perfect square. If you're looking at the SARS-CoV-2 nucleopeptide, basically the capsule of the virus here, that particular antigen. In addition, we have these spike proteins. That's the S is spike protein 2, spike protein 1. And again, the spike protein 2 performs quite well on its own if we're looking at IgG for the SARS. Again, for SARS-CoV-2, what we're dealing with COVID-19, the IgA performs almost perfectly here. You can see that the receiver operating curve characteristic is 1. It's ideal. So we have 0.998 for the IgG SARS-CoV-2 NP antigen, 0.996 for the IgG spike protein 2, and basically 1 for IgA. Now this matters a lot because the concern going into antibody testing was that we would have an inaccurate test because coronaviruses, the common cold coronavirus, is ubiquitous in our population. Many people will have that exposure. And the concern was that these antibody tests would be falsely positive in patients who had had a coronavirus infection before, just a regular common cold coronavirus. And that is the reason why some of these antigen tests don't perform quite as well. So if you add spike protein 1 and spike protein 2 together to the IgA assay, you can see that it performs less well. Still actually quite a good test. Its area under curve is 0.975, very strong test considering everything that we typically use in medicine to make decisions, but it doesn't perform nearly as well as using just the spike protein 2 or the NP protein. So there's exciting news coming up when it comes to antibody testing for SARS that'll help us have a better sense of the population impacts, because it's much quicker and much easier to do antibody testing. The assays can be developed very similar to how, say, a home pregnancy test would work, where you can have blood and have a rapid turnover on the results. And so all of this is very encouraging. So certainly there are antibodies out there that are reliable indicators of infection of COVID. Now it's time to develop the actual tests that work well and function well in the clinical environment. Thank you for listening, and I'll see you next time.